Okay, welcome back. This will be your video lecture for chapter number 26, Hematologic Disorders. Right, welcome back. Let's get started. Let me introduce the chapter to you. All right, hematology, right, is defined as the study of blood and blood forming, also known as hemopoietic organs and tissues. So disorders related to the red blood cells or RBCs, white blood cells, platelets, coagulation, all those we're going to talk about. Let's do an AEMT review. Plasma is known as the liquid transport medium of the blood, and it's made up of about 55% of your blood volume, and 92% of plasma is indeed water. And one thing that plasma does is one piece of plasma anyway, it's called albumin, and that's one of the particles of plasma that keeps the keeps blood, keeps everything inside the vessels. You notice, like in congestive heart failure patients, when their blood pressure is super high, right, and it forces that plasma out of the vessels, it's albumin that brings it back. It has that low osmotic type pressure. We have formed elements as part of blood. That's your red blood cells, your white blood cells, and your platelets. The average person circulates around 5 to 6 liters of blood per minute. We're looking at your liver, spleen, and bone marrow now. So inside eliminated, aged, and damaged blood cells, right? So that's what the liver and spleen. Bone marrow is where blood cells are actually created inside the bone marrow, all blood cells. Our erythropoietin, kidneys and liver secrete hormones that stimulate red blood cell production. And again, about the plasma, the proteins, albumin, clotting factors, and antibodies. I already talked about albumin, but the plasma carries electrolytes and nutrients, those hormones, medications, and they carry other substances throughout the body. So here, the slide here is titled Hypoxia Triggers Increased Release of Erythropoietin, a hormone that stimulates the bone marrow to produce those red blood cells. So EPO here gives it increased division rate, because what happens is these stem cells split into two, and then they continue to split to make more. And that's how that they are made. Let's look at the red blood cells. It's kind of characterized as a flattened disc. It provides surface area for the gas exchange. That's why the red blood cell is the largest cell in the body, so that it can have that big area for gas exchange. About a 120-day life cycle of the red blood cell. An EPO, they're increased to stimulate bone marrow to increase production of red blood cells. This increase is often due if you become hypoxic. The body realizes it's hypoxic, realizes it needs more red blood cells to be carried, and will start generating them. Hematocrit is a measurement of the percentage of blood volume composed of formed elements, and it's around 45%. Then you have hemoglobin. We kind of know a little bit about hemoglobin. Iron-containing protein that carries oxygen and carbon dioxide within the red blood cells. Remember, when the red blood cells leave the aorta and they start going out to the cells, they're fully oxygenated, and they deliver that O2 to the cell. But when they get there, it picks up a certain amount of carbon dioxide and then delivers it back to the lungs to be breathed, for you to breathe out. Sorry, y'all. Got a text. All right. 14 to 15 grams per deciliter on average is normal. Let's look at the white blood cells. Just like every blood cell, it's made in the bone marrow. And so it's signaled by chemical messengers to travel to areas where they're needed. So what ends up happening in this case, what happens in this case is that when you have like a pathogen or a bacteria, and let's say, let me see if I can draw this real quick so that maybe you can get it a little better. All right, these are skin cells, right? And so let's say some piece of bacteria makes its way in through the skin and gets in that extracellular place. And then you have this bacteria right here. Right, mean bad bacteria. So what does it do? Well, bacteria is going to release chemical mediators that are going to come in contact with these skin cells. And when these skin cells start getting sick and dying from this bacteria, they put off their own chemical mediators. And it goes out into the extracellular space. And while that puts off like this, it's like a messenger at this point. And then you have like a white blood cell. And guess what? It picks up on that, right? It picks up on that and it starts following that. It starts following that chemical mediator, almost like a hound dog would sniff out, somebody. And then it will attack that bacteria. So when it says signal by chemical messengers to travel to areas where they're needed, that's what's going on with your white blood cell. Types of white blood cells, well, there's neutrophils, there's eosinophils, there's basophils, there's monocytes and lymphocytes. And they all fight infection. They just do it a little differently than the other ones. Different types of these white blood cells respond preferentially to different kinds of antigens. Platelets. So platelets are fragments of thrombocytes, right? And that's important to remember that that's what they are. And they're activated by exposed tissue collagen and injured blood or vessels. They become sticky and adhere to injured tissue and to each other, and to create something known as a platelet plug. The hemostasis process is completed by the activation of the clotting cascade. And so again, how that works, right, is you have a blood vessel. It's kind of hard for me to draw on this thing. I'm trying though. You have this blood vessel, right? And so if, let's say you have plaque here, it's a coronary vessel, and you have some plaque there, right? Well, those platelets don't know that that's plaque. They actually think that this is a hole. And they're worried that you're going to start bleeding through that hole. But it's plaque, but they don't know it. And they start responding to that scene of the crime there. And what do? They start piling up on this, piling up. And obviously makes it more narrow for blood to flow through that vessel because of all the platelets trying to stick together and adhere to what they perceive to be the injury to the tissue. But obviously that's not the best thing that could happen there, but that's what happens. Hemostasis is the process of stopping bleeding. Hemostasis. There's 3 phases following injury. There's injured vessels constrict to slow the flow of blood. All right, then the platelets are attracted to that area and form a platelet plug, and that causes something known as a clotting cascade. And so here is the clotting cascade pretty much. Here you have prothrombin activator, that's calcium there. It activates prothrombin, converting it to thrombin. Okay? And then thrombin comes down and activates fibrogen, and then that comes down here to fibrinolysis, and it goes on and on. But I would remember the terminology in there as well. There's certain medications that can affect blood clotting, but we should be familiar with the NSAIDs, and we know aspirin is an NSAID, and we know that what it does. So the use of aspirin, an anti-inflammatory, analgesic, platelet aggregation inhibitor. So it stops those platelets from piling on top of what those platelets perceive to be an injury. But we also have to be careful because, they're not going to aggregate on the real injury. So we don't want to give somebody something that can cause that. And so what if this was the case? Let's say you had somebody having abdominal pain, and what's going on with abdominal pain? Let's say they have ulcers and they're bleeding inside their abdomen, and you are looking to provide some type of pain relief, and the NSAID that you can administer as an AEMT is Toradol. And so you don't want to give Toradol to somebody with abdominal pain until we can rule out that they're not bleeding inside their abdomen. And that's the same thing as somebody having abdominal pain / chest pain. We really need to make sure that that's cardiac related chest pain that we're giving that aspirin for, and not, some type of abdominal bleed or something like that. We just have to be careful. We have Eliquis is a blood thinner, and it inhibits blood clotting. And so that's different than a platelet aggregator. And then you can look over here as Lovenox. It's a low molecular weight heparin. It inhibits blood clotting. A lot of people take this. And then you've got some garlic and ginger that's some effect on blood clotting. And the list goes on. And Zolerto, how do you say it? Zolerto, I think is how it's pronounced. Vitamin E, vitamin K, warfarin, aka Coumadin. So yeah. So let's look at some of the blood groups here determined by ABO and RH antigen systems. A, B, both A and B, or no O antigens. And type O can receive blood type O blood. Type O is a universal donor and a universal recipient. So RH positive, RH antigens on red blood cells, they do not have anti-RH antibodies in blood. RH negative, they do not have RH antigen on red blood cells, and they do not initially have the anti-RH antibodies. If they're exposed to RH blood, they develop an anti-RH antibodies, which explains hemolytic disease of newborns. right? And so the child could actually have a different blood type than the parent. And so we got to be careful with that because we don't want that kid during birth is when there could be a mix of blood there to have an allergic reaction. So they always check to make sure that to see what the RH is of the parent. All right, so type A, type B, type AB, and type O. Type A is a surface antigen. It's a red colored circle attached to the surface. Antibodies, anti-B antibodies is a Y-shaped blue in color, like that right there. And if you look at type B is a surface antigen. B is the blue colored triangles attached to the surface. I think I said that wrong. I meant to say, yeah, no, I said it right. It's red. It's a Y-shaped red in color. And then we look at type AB. It's neither anti-A or anti-B antibodies. See? And then you have type O. The anti-A and anti-B antibodies, each Y-shape. Anti-A is blue, while anti-B is red. Let's talk about sickle cell. Complaints depend on the exact nature of the problem. We're talking about sickle cell, warfarin, uses, leukemia, and excessive platelets. So signs and symptoms of a hematologic disorder. They're tachycardic. They're breathing fast with tachypnea. They have dyspnea. They're difficulty in breathing. Fatigue, malice, weakness, pallor. Their lymph nodes could be swollen, tender. They have fever, hematuria, and petechiae. And petechiae, remember this definition, is pinpoint hemorrhages that may appear like a rash. The purpura, hemorrhagic area in the skin is greater than 3 millimeters in diameter. Unusual bruising or bleeding. All these are still signs and symptoms of hematological disorders. They may have pruritus, the itching, abdominal pain, joint swelling, syncope, jaundice, and night sweats. A lot of times you can look at the patient's medications to see if they possibly have some type of hematological problem. They take vitamin K. Okay. So this is a picture of purpura. All right, so this is purpura. And so basically what this is that flat discolored spots on the skin or mucous membranes. Let me get my pen up here. Right, and so hang on one second. I'm trying to get it. My pen's not working. But anyway, it's caused by bleeding under the surface. They're about 3 to 10 millimeters. They're red and purple. They're a big factor, like when you see this as possibly being a platelet disorder or some type of hematological disorder. Now you can barely see my pen, but that's what I was trying to point out right there. If we look at petechiae, right? So this is petechiae. And you can see petechiae rashes in a lot of different scenarios. And what it represents is very similar to the last slide we looked at. It represents like bleeding under the skin, tiny capillary bleeding. And a lot of times, like, you have like a disease like meningitis will cause this attack of those blood vessels. But it's a hematological disorder. It's something to be aware of. So we're going to determine the need for oxygen, fluid administration as appropriate. They're not hemorrhaging, like majorly hemorrhaging here, but this usually points out of some type of underlying disease process that's going on. So reactions to blood transfusions, flushing, pain at the infusion site, the complaint of chest pain, back or flank pain, restless or anxiety. And the problem with this sign is if you're giving blood because the patient's probably in some type of, they're in shock, right? And the problem with giving blood is you have somebody who's already restless and anxiety and you're giving them blood. Nausea, fever, and chills. Fever, though, is different because fever is not a normal sign of shock. So if I'm giving somebody blood and they spike a fever, it's probably secondary to my blood transfusion. Even though we usually type and screen blood before giving it to a patient, there could be something wrong with that blood. We would need to stop that administration of blood. And the list goes on. Flushing, pain at the infusion site. Just again, I think this was the last. Hang on, back up 1 second. A lot of that's mentioned right there. It's just kind of a repeat. So when we talk about red blood cell disorders, anemia, right? Abnormally low hematocrit. And the causes of this is decreased production of red blood cells and increase in the destruction of red blood cells, or simply losing red blood cells to hemorrhage. These cells do not receive enough oxygen for energy production. It also could be a loss of iron because hemoglobin needs iron to be present. So sometimes you can be anemic secondary to an iron deficiency. So signs and symptoms, fatigue is a big one. The patient just has that look of illness, a pallor look to them. They could be trying to compensate and be tachycardic. They can be short of breath. And in severe cases, chest pains and signs of heart failure. There is some red blood cell disorders. There's a aplastic anemia, iron deficiency anemia that I just mentioned there earlier. A perineurocosis anemia and hemolytic anemia. Sickle cell disorder is a genetic disorder. It's common in people of African, Mediterranean, Middle Eastern, Caribbean, South and Central American descent. The red blood cells take on an abnormal curve. It's actually not the red blood cell, but also the hemoglobin takes on that S shape of sickle cell shape appearance. These RBCs only live 10 to 20 days. And here's another slide. It's basically explaining what I just said. What can end up happening here, though, by this slide, is that you can have what they call a microinfarct. And they're small, tiny in the capillary area where it's small, the vessels are tiny, and you have this big sickled shaped red blood cell, and it blocks that blood supply, and it can cause necrosis or tissue damage from that. It can even be, some say it can even be described like a stroke, like stroke symptoms, and even in some cases like a TIA symptom of patients who have sickle cell because of this. So yes, again, it just continues to tell you about the sickle shape of the cells, or the hemoglobin takes on that S shape. These cells are more prone to clumping together, and that clumping of the sickle cells with subsequent obstruction of the capillary beds is called vaso-occlusive crisis. And so you see it happen in your hands, feet, or even in the brain. Just anywhere where you have those smaller capillaries. Then we have white blood cell disorders. The big one's leukemia. The cancer causes bone marrow to rapidly produce large numbers of abnormal white blood cells. And these actually crowd out the normal cells, resulting in an anemia or bleeding or even infection. Because what do white blood cells do? They fight infection. If there's too many of them and they start clumping together, then they start to be able to lose their function to fight infection. Some of those signs and symptoms include bruising, bone pain, your spleen can be enlarged, swollen lymph nodes, fatigue, and infections. So again, cancers of lymphocytes, B or T lymphocytes, cause lymphocytes to the lymph nodes, localized to the lymph nodes. Hodgkin's or non-Hodgkin's lymphoma. Survival rate for Hodgkin's lymphoma is very high, relatively high for non-Hodgkin's lymphoma, and patients may have a history of profuse abnormal night sweats. Multiple myeloma, cancer of cells in bone marrow. These are abnormal cells. They multiply, they crowd out normal cells. Decreased production of blood cells result in pathologic fractures of the affected bone. Not good. So platelet disorders, or thrombocytopenia, is the low number of platelets. Remember that term. Platelets reduce in number or impaired by leukemia or bone marrow disorders, and thrombocytosis increased platelet counts, resulting in the risk for bleeding and clotting. Please remember that term as well. Hemophilia, inherited disease. It's a deficiency in certain clotting factors. Painful swollen joints, abnormal menstrual bleeding, bleeding gums. These patients tend to bleed a lot, and so especially really bad if they ever have a traumatic event. A simple fall or something like that can really be a bad day to somebody with hemophilia. So the treatment is replacement of a specific clotting factor. They have to know what that clotting factor is, and they go to the hospital and actually receive that. Blood clots and deep vein thrombosis, or DVT. These blood clots form in a deep, large vein of the leg, pelvis, or arm. And if that DVT breaks or loosens, it can cause a pulmonary embolism. They have to receive anticoagulant medications like heparin. So DIC, need to know what this is. You need to know what it means. It results from systematic overactivation of clotting mechanisms. And this can happen through blood transfusion reactions, sepsis, surgery, or severe trauma. Hematology, study of the blood and blood forming organ. Oh, we're at summary. So that's what we talked about. Blood compromise of plasma, the transport medium, and formed elements. So that's what blood's compromised of. Plasma is the Uber for the red blood cells, white blood cells, and platelets. Plasma, proteins, antibodies, clotting factor, electrolytes, and nutrients we talked about. Red blood cells carry oxygen and carbon dioxide bound to hemoglobin for gas exchange. We mentioned that. We talked about a decrease in red blood cells from blood loss. We talked about the abnormal shape of red blood cells, just in the case of sickle cell disorder. And we talked about the antigens. All right, this is the video lecture for this chapter. I'll be putting more out soon. Thank you.